Primarily be focusing on assessing T1 through T5. Okay? As I had also said before that, some practitioners like to do the full assessment at each level and move on to the next level and do the neutral flexion extension. I personally practice where I do the neutral position assessment first, decide and find out what I find objectively with my assessment, then I'll check in flexion and an extension, because then I can kind of break down in my head, each segment at a time. All right, so first couple things that we want to do is establish some ground rules for when we do our assessment. It's very important that we're utilizing our dominant eye and have it closer to the segment that we're assessing than the non-dominant eye. Does everybody know or remember how to find their dominant eye? Everybody turn their head to the right and look at the clock. What I want you to do is make a small window with your hand and look at the clock so you see it with both eyes. Now what I want you to do is I want you to close one eye and then open that one and then close the other and close the other eye. So, which one of your eyes kept the clock in view? It's going to be different for everybody. That's your dominant eye. Anyways, for those of you who did see a difference, the eye that was still focused on the clock and didn't lose sight of the clock is your dominant eye. The other couple things to know is just anatomically, the transverse processes of T1 are the widest of the thoracic spine. And as you go down closer to T12, they get smaller, 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 and T12 is the narrowest in terms of transverse process extension lateral. And then, of course, you're always going to look for your landmarks to get started, so you can find the the spinous process of C7. When it becomes more prominent in flexion, take their head back into extension. Whichever spinous process, C7 shouldn't shoot forward like C6 will. You'll know that you're beyond C7. So you come down off of that onto T1, spinous process. Go off the spinous process, get to longissimus, and just past longissimus is the transverse process and where you want to be. If you go too lateral, and it's the most common mistake, you'll be out on the rib, and you won't get a good reading for what's happening at the spine. All right? So we'll take time to kind of go through that with you. Let's see. Okay. So somebody come on up. Meredith, you know what, your hair is up, and I just happened to notice it. Would it be too much trouble to have you come up for the demonstration? Great. Sit comfortably and have your feet resting on them. Comfortable? Okay. So what we first... All right. So we're looking at our patient again. If I was right here and unfortunately in front of you. Okay. What we want to first do is find C7. Sorry? Thanks. So we want to find C7, T1. So go ahead, bend forward. Okay, so we see a little bit of the protrusion here of the spinous process. Now I've got two of them there, so I just want to see which one turns out to be the C7 and not the C6. I come back in a little extension. That one still stays, so that top one was definitely the C7. So now what I want to do, and this is, I'll try to find it, and then I'll step to the side so you can kind of see it. Come in here, down to T1, okay? I'm going to slip just lateral off the spinous process, find longissimus, and I'm just going to go just lateral to that. And that's where the transverse process is going to be. Okay?
Can you really feel the transverse process?
Yep. because there's the soft tissue. No. That's a very realistic question. Absolutely. Because as I talk you through coming off of something hard into a little gutter, then going onto something soft, then off into a little gutter, the only thing there to feel is the transverse process. What you will need to do, though, is sink down through the level of the skin tissue, okay, and any fascial tissue, so that you can feel that firmness. And if you wanted to just double check it, come a little bit more medial on longissimus and say, well, that feels like a muscle. Oh, that feels more like something other than a muscle. It's a transverse process. And you're going to find that in the upper cervical spine, at least for the upper three, spinous process is going to be pretty much in line with the transverse process. Sorry? Yeah, 1, 2, 3. That's why they break it down into rule of threes. The first third, second third, and the third third. And then 10 follows the last, and so forth. What?
And then the fourth.
And then the other three. So I'm here now. I'm going to put my thumb there. And I'm also going to now find the same thing on the opposite side, right there. Okay. So I'm going to assess, and I apologize again for my back being to you. Well, what we could do to also make it easy, can you straddle? Okay. Is that okay?
Yeah.
Okay. Doesn't hurt your hips? Okay. So what I'm going to come here, I'm going to get into position, and here's what you're going to need to do. You're going to need to kind of look down over your thumb. So you're going to look to see, now if I was bent forward, you'd see this even easier. I'm going to look to see symmetry from my thumbs left to right. If I see this, one's more prominent and one is further away from me, then I know that there's some kind of a rotation. But I can't really tell anything about just looking at one segment. Okay? So now I'm going to go down and I'm going to look at T2. Good rule of thumb, almost literally, to keep in mind when you're doing your assessment. It's always helped me, and I still do it to this day, no matter how basic it seems. I come back to the spinous process, I go down the next spinous process, and I work my way out. It's just my habit, my traditional way of assessment, and it always guarantees me that I know that I'm on the right segment. Some people just go down, 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 and that's it. Okay. I like to always go back and know that I'm where I want to be. Okay. So I'm assessing in neutral. We're fine at T1. I come back, come down to T2 spinous process, and I actually find a little more prominence on the right side. Okay? Another thing that can be very helpful, especially as you get down into the scapular region, just have your patient have their arms kind of wrist crisscross in front of them, brings the shoulder blades out of the way. But don't let them flex. Neutral. Someone say something? Okay. So again, I feel some prominence on the right side. I'm going to go down now to T3. And I feel symmetry at T3. So if I felt symmetry at T1, asymmetry at T2 with the right more prominent, but symmetry at T3, what are we thinking about maybe what kind of lesion, a type 1 or a type 2 lesion? Now, you're going to have to convince me a little more than that. Why would it be a type 2? One segment.
It's just one part.
Now I believe you. Okay, good. But that's exactly how you want to do this. You want to play that game with yourself all the time. Is it really what I feel? I have to check the next level. Let me go down, check the next level. T4, symmetrical. T5, now a little off from the level of the spinous process, and I feel asymmetry again. I feel asymmetry on the right, just like I did with T2. So, if I'm stopping my assessment here, it kind of makes it hard to determine is it a type 1 or type 2. Because what if the type 1 is all down here and that's just the last part of it? I don't really know that. That's why I really have to do the rest of the assessment all at one time. But for the the sake of this lab, we're only going to focus on the upper T spot. But so far, you nailed the type 2 perfectly at T2, and now we're kind of a little suspicious about T5, one way or the other. So we did it in neutral. We started with the spinous process, worked off the spinous process into the gutter, over the longissimus into the next gutter. Felt for the transverse process. Came back to the center line to do the same thing with T2. Same thing with T3. Same thing with T4 and 5. Now what we're going to do is challenge it in flexion. Right? And we're going to pay careful, no, I'm not going to say it, and we're going to see what we come up with in flexion. Let's come back to T1. Okay, here's what I'd like for you to do is just to allow your head to flex forward. Good. Hold there, and I feel symmetry. No trouble. Come back up. And again, flex down, T2. Come back up for a second. Okay, flex to T2. Flex. And one more time. Still feel it prominent in flexion. Alright, so now what do we do about that? What lesions, osteopathic lesions, get worse in flexion? ERSs, correct? Extension ERS lesions. Now, if I'm already finding that it got worse in flexion, or didn't improve in flexion at least, it stayed the same, what can I at least say about this level? Is it a major motion loss or a minor motion loss? Why is it major, Nina?
Because you were able to see it when she was neutral.
That's right, and you're absolutely 100% correct.
He was able to see that it is not right when she was in neutral, even when she was not flexed.
Yep, that's it. We know it's not a minor. It's got to be a major. Now the reason why I didn't start telling you about that before I started to assess is because what if T1 was level and neutral, but all of a sudden became asymmetrical in flexion? It's a minor lesion. That's how you start differentiating, and I told you when you had your hands on someone, we were talking it through, it was going to be a lot easier to see that concept. So, we know that it stayed asymmetric in flexion. Let's go back up and check T3. Nice and neutral first. Flex. Good. Stayed symmetric. Come back up. T4, go ahead. Stayed symmetric. And T5, go ahead. Stayed a little bit prominent on the right again. And again, because we're stopping our assessment here, we really can't decide which one it is. But we know that it's at least a major lesion. And because it stayed asymmetrical, if we only found it at that one level, what kind of an osteopathic lesion would it be? We found it in flexion, so it must be an ERS, and it was more prominent on the right side, so it must be an ERS what? Right. That's it. That's it. Okay. Does that make sense to you guys?
What do you mean you found on the right side? The right side was more prominent.
The right side was prominent in neutral, so we know it was major. And it stayed more prominent in flexion. And it stays more prominent in flexion because the transverse process is back, because what's not happening to the facet?
It's not opening.
It's not opening. All the other ones that are symmetrical are opening. They're going forward with the flexion motion. So now we're going to challenge the segments in extension. Go back up and do it again. Again, some osteopaths do this. T1, neutral, flex, extend. Great. T2, neutral, flex, extend. Great. T3, flex, extend. Great. Some people also do it like this. Flex, T1, okay, flex a little more. T2, okay, flex a little more. T3. I kind of like to have you come back to neutral and then go into the other motion. think it's great practice. You get to feel motion under your thumb, under your hands, and it just enhances things. As you get out 2, 3, 4 years later and you walk over to the spine and says, oh, this is old hat, I know how to do this, then you could jump to doing it all at one time. But I really think for the purposes of learning, I strongly suggest you do it in this way. Right? So now, with looking at extension, the one thing that you want to be careful of is when you ask your patient to extend, that you're getting extension in the T-spine and not extension at OA or mid-cervical spine. So what I'll suggest that you say to them is just gently tuck your chin and bring your head back. Now we're getting thoracic extension. Right? Can you see that difference? Do it all yourself. Just put yourself in forward head posture. And now try to extend the T-spine. What goes first? OA and cervical. Right. So how are you going to expect to get a good finding during your extension assessment if they're way out of position? So just cue them like that. Just a simple thing. I want you to do this with your neck and then come back.
What if they really don't have, like they have minimal extension?
If they have minimal extension, then what you could do instead of having them do it actively is you then do it passively like you learned in manual therapy too. Let me bring you into extension. Let me bring you to extension. Let me bring you to extension. Or you can have them prone and just do a simple P to A to see how well the segment is. If you're already noticing that they're that far forward and have a thoracic kyphosis, let's face it, there's a good shot that there's a lot of FRSs in that lower cervical, upper thoracic spine. And that's pretty common. ERS is up on top, FRS is down below. So, T1, just gently tuck your chin, retract. Good. Symmetry. T2, same thing. Oop, tuck your chin. There you go. Now, what did we find at T2 at neutral and inflection?
Prominent right.
Prominent on the right. What I'm finding now in extension is there's symmetry. Why might that be the case? Something that I didn't tell you yet that I was waiting to get to the thoracic spine to discuss. Chad, what's the idea there?
Well, I was thinking since the right side is having problems moving, the left side's coming back with the extension and making it even now?
That's exactly it. I couldn't have said it better myself.
I was saying since the right side is having the problems with the motion when you're coming back into the extension, the left side is now evening out with the right side.
The right facet in an extended lesion is the one that's dysfunctional. And it's most dysfunctional as you're trying to go into what motion? Flexion, where it needs to open. Coming back in extension, it's got no problem. It's already in extension, and the other facet joint is not the dysfunctional problem. So in extension, extended lesions are symmetric. In flexion lesions become symmetric. Because the opposite happens in flexion. The facet joints are already stuck open on one side. And because the problem is the side that's stuck open, the other facet can open up just fine to go into full flexion. So ERSs get better in extension and worse in flexion. FRSs get better in flexion, worse in extension. And when I say worse, I mean more asymmetric.
Can you just repeat that word for me?
ERSs become more asymmetric in flexion and level out or become symmetric in extension. Thank you. FRSs, we're right on time. At least your computer's working.
Yeah.
And FRSs become more asymmetric in extension, but level out or become symmetric in flexion. Does that making sense to everybody? Good. So my assessment would continue further down with that extension component. So I would come back, find the spine of the scapula. Now I know I'm at T3. Come right out. Nice and up tall. Bring your head back in retraction. Good. Symmetrical. T4. Again. Symmetrical. And T5. We have symmetry in T5. So we're kind of rather certain now. I shouldn't say kind of rather certain. We are more certain now that her T5, even though we didn't assess T6, is behaving more like a type 2 dysfunction. And if we remember what's on the list for a type 1 dysfunction, what do we know about it in terms of flexion or extension? It does or doesn't correct with flexion or extension. It doesn't. It stays in the neutral coupling mode of side bending one direction and rotated opposite. It's not influenced with movements. It doesn't correct when you engage the facets. It's not like a type 2 dysfunction. Your type 2 dysfunctions will correct. Your type 1s will not correct. Okay.
Sorry, can you repeat that? I thought
Sure.
type 2, you would see it more if they're in flexion, not that they get better.
Type
You get better now.
need. Which dysfunction do you want to? Can I use it? Just pick an example. Okay, an ERS right. Okay, what's the problem? And we can talk about it as a whole class. I don't mean to single you out. ERS right. Which facet is the problem?
The same side, the right side.
Right side. Okay. All right. Is there any problem with the left side? No. Okay. So the left side can move freely. When I go into flexion, right facet can't do what?
It can't open.
Can't open. Arthrokinematics. What's the arthrokinematics? Can't open because it's stuck,
Shut.
which now forces it into what? Into it being more prominent now on the right side during flexion because the left one can go. The left one we all said is not dysfunctional. When I come back into extension, again, left's not dysfunctional. So it can close just like the dysfunctional side is closing. That's why there's symmetry in your palpation. Because for your type 2 lesions, they get worse in one direction and they correct in the other. And I went on to then say that ERS lesions correct or are symmetrical in extension and are worse or asymmetrical in flexion. The FRS lesions correct or are symmetrical in flexion and can become more asymmetrical in extension. That's how you're assessing the spine for type 2 dysfunctions. What would a type 1 dysfunction look like? Right, and neutral, we would see it. So what would we see in Meredith? I get to T1, perfect, symmetry, beautiful. Now this is just the example that I'm using. I'm not doing the actual diagnostics. T2, prominent on the right. T3, prominent on the right. T4, prominent on the right. T5, prominent on the right. Because all of those segments are rotated to one direction, and if I were to have her take off her tank top, I would see the side bending going to which side? The left side. Exactly. That's how you're picking up your type 1s, which is why it's perfect to have somebody expose their back as much as you're able to get them to expose it. You will see type 1 curves easier, and you will feel type 1 curves when you're palpating.